All right, I'll begin.
Thanks, Allison.
After graduating with a BA in biology from the University of Rochester, Dr. Gail Schupak earned her DMD from the University of Pennsylvania School of Dental Medicine in 1983. 2 years later, she received her certificate in orthodontics from the Columbia University School of Dental and Oral Surgery. She has been in orthodontic practice since 1985 and has been a clinical assistant professor at the New York University College of Dentistry with an appointment in the Department of Orthodontics since 1993. So please join me in welcoming Dr. Gail Schupak.
Hi, everybody. And I used to actually teach at Columbia before I taught at NYU, but it was a little far. So I was telling the people who were on the screen before you guys were allowed in. Feel free to unmute yourselves. Ask me questions. You don't have to put it in a chat box. Just interrupt me. I'm happy to answer any questions, any concerns. You name it, I'm here for you. So I have a lecture-ish sort of thing. So I could do that now. I can share my screen. There we are. Let me pull this up. Okay. Do you see me?
I don't see your screen yet.
Wait a second. Let me do this. Wait. Sorry. Let me just get out of here. Okay. That's my screen. Oh, here we go. Got it? Okay. We're good, right?
Yes, perfect.
Okay. All right, slideshow. In the beginning. Okay. So this is me. So this is a PowerPoint that I used for, I think you guys a number of years ago. So that's me. I was just on a call with the people from Alpha Omega, and I'm the president-elect internationally. So if anyone has any questions about AO, I'm your person. I'm also one of the organizers of the Greater New York Dental Meeting, which is the biggest dental meeting in the US. And I'm in charge of anything ortho at the meeting. So if anybody is interested in going to the meeting, we should all go to the meeting, it's free. And it's gonna be in person in November. But what I can tell you guys, and this has nothing to do with my background thing here, but this is for you if you are interested in going into ortho. Do some research, do something. And if you can present a poster, if you can present something, get it together and present it at the Greater New York Dental Meeting. We're always looking for students to do presentations. And that's a great thing to have on your resume when you're applying to graduate programs, whether it's ortho, perio, anything. It's a really, really important. And because the Greater New York Dental Meeting is a national meeting, it gives you extra points when you're applying to postgrad programs. So that's my little plug for the Greater New York Dental Meeting. So let's talk about, I'm not going to do too much didactics, as I was saying before, but let's, why do ortho? What's the point of ortho? It's aesthetics, it's function, it's helps the restorative dentist, pediatric dentist. Now everybody's talking about sleep apnea. Of course, it helps with, expansion, helps with sleep. So if we're talking about if we go back to dental aesthetics, helps us with the smile arc, helps us close our lips together, helps us with symmetry, cants, helps us fill the buccal corridors, helps us line up the margins of the gingiva, and you know, it helps us all over the place. So when we're talking about facial aesthetics, it's interesting how orthodontics can, can do as much, if not more, than plastic surgery. We can make the lips fuller, we can make them more symmetrical, competent. We can make the whole maxillary arch look better or worse. We can change the facial height of people, not just with orthodontic surgery, but with tooth movement. We can make the chin look fuller, more retrusive, and we can change how people look at nasal prominence. So, of course, the bottom line is to make sure that people can eat, they can chew properly, that their gums are going to be better, hopefully, after ortho, and it'll be easier to brush and floss. The TMJs will be protected. Speech is an interesting kind of subject. Sometimes, people think that because their teeth are straighter and their bite is better, that their speech is going to change, but that doesn't necessarily happen. But if you get a kid early enough, maybe you can help with speech improvement. And of course, we want to make everything nice and stable so that things don't start moving around after you've restored it. So of course, there's class 1, class 2, class 3. And I think we're going to talk about different types of appliances. So let's just keep going. You know what? We're going to talk about clear aligners, that's Invisalign, or, there's a lot of other brands out there. Pluses and minuses for both things. So braces, should they be fixed or should they be removable? There's so many different things that we can talk about. And when I go through the cases, I don't think you guys want to look at all this stuff. You've been watching your, okay, so let's talk about a person. It's more interesting, right? So this is a guy, and you guys can go off mute because I'm going to ask you some questions, okay? This is going to be interactive. So this is a really sweet guy, comes to see me. Somebody chime in. What do you think his chief complaint is? What do you think he was most concerned about?
It's midline
between
diastema.
Diastema.
Yeah, the diastema between 8 and 9.
Diastema, right? So he didn't care that he has a buccal crossbite. So if you look over here, you can see my arrow, right? Yeah. So you can see that the upper teeth are completely enveloping the lower teeth. See this? That's a buccal crossbite. So if you guys ever see something like this, a buccal crossbite in a kid, young kid, fix that as soon as you see it, you should fix it, because this is probably one of the hardest things in orthodontics to fix. Okay. So of course, yeah, this is why he came to see me, but of course, this is what I was looking at. Look at that. That's hard. That's
Dr. Schupak, do you fix that buccal crossbite by expanding the mandible or kind of restricting the maxillary region?
You heard this before, right? All right, here we go. I'm going to tell you. Let's do it. Okay. So he's African American. So he's, this is normal for him. Class 1 bimaxillary protrusion. That's normal. It's not pathological. That's good. And so we're going to talk about these Sure Smile wires. Now I'm going to pause share. Can I do that? Resume share. Wait. I guess I wait. Never mind. Let's go back. Resume selection. You can see me, right? So if I hold up something,
Yes.
maybe, maybe I should go to my, no, it's okay. Okay. So I'm going to show you what these SureSmile wires are. So ordinarily, I'll just show you a case. Okay. So say this, wait, oops. You know what? Sorry. How do I get out of?
If you go next to where it says like stop video or start video, there'll be a little arrow. If you click on that arrow and you go to choose a virtual background, you can, don't click the actual stop
Oh, I
video.
see. Yeah. Okay.
Click the little arrow
Yeah.
and just choose virtual background, and then you can get rid of your filter, and that way we can see what you're showing us.
There it is. Okay.
There you go.
Okay. Okay, good. Perfect. So this is braces, right? Clear braces like this guy has. Okay. So what we do is we make the teeth nice and straight, but sometimes just, what Michelle was saying before, it's hard to coordinate the top teeth with the bottom teeth, right? So what we do is we do a digital scan and we take some x-rays and some photographs. And then what we do is we make some wires, these SureSmile advanced wires, and these wires, you see it? Yeah, okay. So these wires are bent by a robot. So we can never do the tips and torques and stuff like that are in these wires. They're really, really small and interesting, and these wires are made out of copper nitai. So you can tie this in a knot and it bounces back. But the bends are in there to specifically move each individual tooth into its perfect position. So what we do, and I don't know if do you guys know about what a ClinCheck is or anything like that for Invisalign? But what we do is we virtually straighten the teeth. And then once the teeth are straight, we make these wires on a model of perfectly straight teeth for this particular person. And the wires move the teeth so that just like what Michelle was saying, do you expand the lower and constrict the upper? Yes, we do. And also we intrude the side that's extruded. So the left side, the upper is extruded and the lower is extruded. So we even out the teeth. And I mean, this wire is not for that particular person. It's for a different person. But so the arches are coordinated, and these SureSmile wires really help us get to that finish line a lot faster. It's not so easy to get those arches coordinated. So I did use these SureSmile advanced wires for that. Okay. Oops. Resume share. Okay. So that's a close-up of the wire. I tried to take that picture before. Okay. There's a lot of little teeny weeny bends in the wire that help with the tip and the torque of each individual tooth. So here he is, and of course we've got these blue bite openers so that we can get these teeth, the top teeth, to go palatally, and the mandibular teeth to go buccally here. So here he is at the end. He's got this bonded retainer because, of course, his chief complaint was that midline diastema. And you can see here what happened to his gingiva. Oh, wow. He's got a lot of overgrowth of the gingiva, so he needs a nice trip to the periodontist. And of course, he had these decalcifications before the orthodontic treatment, and then he'll have a little cosmetic dentistry done there. So this is before, this is after. You can see how the plane of the occlusion has dramatically changed, right? And you can imagine this guy is like 6'2", built, you know, fellow, and his bones are pretty dense here. So this was not an easy case. And here he is before and after. One thing that you'll notice is even though his bite is better, he's not filling up the buccal corridors as well as he used to. So cosmetically, yeah, his space is closed, but the broadness of his smile has been compromised. So you get the good with the bad here, right? Okay. So, oh yeah. So another nice advance is light force. And so what I do is instead of, oops, I'm sorry. So getting back to the brackets before, I don't really have any light force cases to show you, but these are light force brackets. So what happens is instead of treating the case with regular braces and like I did for years with Sure Smile, which was very advanced. Now what we do is we start the 3D imaging of the case from the very beginning. So we take our x-rays, we take our pan, our Ceph, our digital models, our photographs, and we completely straighten the teeth virtually. And then instead of building wires to fit the brackets, we actually have these brackets, and these are the light force brackets. And we put the brackets on. These brackets are 3D printed. Each bracket is 3D printed for that particular tooth, okay? So in other words, with our old braces, these guys, every lower second bicuspid was the same as somebody else's lower second bicuspid. In these brackets, the lower second bicuspid is specific for this patient. It's specific for where that patient's tooth will be when the teeth are completely straight, number one, and specific for that patient's anatomy. So each bracket is 3D printed. And how do we get the brackets on the teeth? We do indirect bonding. So in other words, instead of sitting there, I don't know if you guys have braces, and you put the braces on individually, what we do is we put the braces on. What we do is we have the brackets already placed on the model, and then we have a pickup impression. This is all done this is not done in-house here. It's just done at the lab. And then we put this little jig on, and then the brackets are on the perfect spot on the patient's teeth. So this is the next step. This is even more high tech. And then what's great is that you use your own wires. So you use your own plain flat wires. You don't have to bend wires at all. And the cases treat out remarkably fast. So it's really cool. So we'll get back to Invisalign now. Okay. So this is a patient. She was actually best friends with my Invisalign rep, and she said, "Oh yes, definitely use my case." So so what do we see? So who wants to tell me what this young lady's chief complaint is? Don't all shout out at once.
The asymmetry of her smile.
Yeah, that's good. Yep, that's exactly right.
Dr.
So,
Schupak,
yeah.
before we go too far here, on the 3D printing, Is it significantly more expensive? And did you say the treatment occurs faster?
It's faster, and yes, of course, there's a lab fee. I think it's, don't quote me on it, but it's like $650 a case, something like that.
More than your
No,
other?
that's what you pay from the lab.
Oh, okay.
But you don't have to buy the individual brackets either. So, I mean, not that they cost that much, but so it's like maybe like $500 more, but you pay, you charge the patient the difference. Now, the interesting thing is it's going to take less time. So, you've got to build that into your presentation when you're sharing that information with the patient. By the way, you're going to pay a little bit more money, but you're going to have braces on for a lot less time. Well,
I was just about to ask,
that's attractive.
You offer patients the option, or do you kind of?
Yeah. Yes.
Because financials are involved, you would have to.
Mm-hmm. Absolutely. Yeah. So, yes, you're right. This patient's chief complaint was the asymmetry. And of course, she had braces when she was younger, but she should have, what should she have had done when she was a kid that she didn't have?
A palatal expander.
Yep. There you go. Good. Okay. So pretty normal, she had her wisdom teeth out. So here she is. So with Invisalign, what we do is also we take all those same exact records, right? And we treat the case out so that we make her smile and her teeth perfect on a model. And then we treat out the case so you get a series of clear plastic aligners. Each aligner makes the teeth a little straight, a little straight, a little straighter. So you have your initial and you have your endpoint, and then you have a bunch of aligners that take you from point A to point Z. So this is Invisalign. And so on some of the teeth, you're going to have some little attachments. Okay. And each one of these aligners is made on a model of the teeth where the teeth are a little bit straighter, a little bit straighter, a little bit straighter until you get to a point where the teeth are hopefully perfect. Now, there are other companies besides Invisalign, and another company that I've started using is called Spark. This is not an advertisement, but just to let you know, it's not just Invisalign. These are maybe a little bit more clear than Invisalign, a little bit less money. The company is not as efficient as Invisalign, but whatever. I mean, the aligners are great. I think they're prettier.
Dr. Schupak, we have a question in the chat. I can ask it for Rumi.
Yeah, go ahead. Yeah, sure.
How do you determine whether you can use aligners, which are probably cosmetically preferable for patients, or traditional bracket therapy?
Okay, so that's a good question. So let's talk about that. So as far as braces are concerned, every time you put braces on a patient, you are extruding teeth. So if you have a patient who already has an anterior open bite, braces are going to work against you no matter what you do. If you have 2 layers of plastic between the back teeth, you're constantly intruding the posterior teeth. And so it'll help if you have an anterior open bite. Just by wearing these and not even moving teeth, that's going to help close down the bite. However, let's think about it. If you have a very deep bite, this is not going to be your best choice because you're constantly going to be intruding your posterior teeth. Now, you can build in some bite platforms here and keep the bite open, which is what we do. But there are certain cases that are definitely better treated with aligners, and definitely cases that are better treated with braces. So that first case, the gentleman with the buccal crossbite, the advantage of treating someone like that with the aligners is that the plastic constantly keeps the teeth apart. So you constantly have something in between the back teeth. The problem is that expanding with Invisalign is not that efficient. So wires are much more efficient as far as expansion is concerned, arch coordination is concerned. You've got to pick your patients. Some patients, like I was on a FaceTime call with one of my patients who happens to be in Florida right now. And I said, "Oh, Amy, how many hours a day are you wearing your aligners?" "Oh, 8, 10. I'm like, "What? Are you kidding me?" So, even though she promised up and down, of course, that she's going to wear them, I'm going to be the best patient you've ever had. 22 hours a day, 7 days a week. And here she is. And you wonder why it's, her her teeth aren't tracking with the aligners. No, you don't have to wonder. So a patient who's not going to be compliant, obviously, is going to be a better braces patient. But on the other hand, she's in Florida. So she's, it's COVID. She moved down there, and who knows when she's coming back. So we've got that. So, there's a lot of advances these days in teledentistry. So with aligners, you can do a lot more teledentistry than you can with traditional braces. Although with the light force brackets, you put a wire in and you can monitor, you can do virtual monitoring and see when and if they need to come to the office. Because these days you would like to see the patients as little as possible, right? Because people don't want to travel. And you know what? I think people are going to get used to that, not coming in so often. And they're going to like not having to come to the office so much. So less is more. Let's just say that. And the other advantages, of course, are cosmetic. You don't see the aligners. If someone has a speech issue, if someone has a lisp and they have aligners in, it's not, it's not good for people with speech issues. So if you have a patient comes in because they've got speech problems, I wouldn't suggest aligners or lingual braces. I don't really use lingual braces very much anymore. There's too many complaints and I don't want to hear it. So I don't use them that much anymore. But, there are lingual braces, inside braces. Did I answer? There's so many more things I could say, but that's part of it.
Yes, thank you, Dr. Schupak.
Okay.
So Dr. a quick question going off that.
Yeah, go ahead.
For a case that's something as simple as like mandibular crowding in the interiors or maxillary crowding in the interiors, because you said aligners are not as effective for expansion, you would recommend traditional bracket therapy in most instances for those?
Like a lot of expansion. I'm not just talking about a little expansion, but a lot of expansion.
So then in just general crowding, what is it, the patient preference for cosmetic, what they would like given their age as well as a factor, or in terms of effectiveness between aligners and brackets?
So, another good case for aligners is people with spaces between the teeth, because as you're closing up the spaces, as you're moving the teeth together, the tongue is prevented from pushing the teeth because there is a plastic in there. So that's another good case for aligners. I had a patient come in today and her central incisor was like tipped this way and this one was tipped this way. That's not a good case for aligners. It takes a really long time to upright those teeth. You put some braces on a patient like that, and by the next visit, that's finished. It's corrected. So you've got to know. Well, one of my friends, Willie Dion from Toronto, he's a big Invisalign speaker, and he says you've got to think like plastic. You've got to know which cases are going to be the winners? That's not a winner case. This is not a winner case either, really. I mean, I have to be honest with you. This is a case where today I would do something called a maxillary expansion appliance. I would, not that everybody wants to use one of those, but there are palatal expanders that you can use for adults these days, which I didn't use before a couple of years ago. So I don't know that she would have wanted to have done it anyway, but I would have definitely given her the option.
Can you use that without surgery?
Correct. You use some mini screws to hold in the appliance.
How does that work?
That's a whole other topic, but
I had a feeling.
yeah. So you know what a palate expander looks like, right?
Yeah.
Because I could go back and get one, but there's so the palatal expander is anchored to the palate in an adult with some mini screws, and so without doing surgery, you can actually, in not every case, but in some cases, you can expand the maxilla non-surgically. Yeah. So this is our friend after about a year of Invisalign, and you can see that she's got the bonded retainer. Wait a second. Oops. And that's going to maintain that lower arch. And on the top, she got a removable retainer. Now, if you notice, her cusps are really flat here, right? Because when she had this nice crossbite, these teeth all got very flat. Well, here, the tooth is still flat. So in order to keep this molar in the ideal position, it would be nice if she went and had some restorative dentistry to build up those cusps again so it doesn't relapse. So she's super happy, nice, much broader smile. She's filling out her buccal corridors much nicer. Here's someone who had braces already, and she's actually from England, and she's actually missing her upper right second molar. And this is her wisdom tooth. So she's very narrow also. So what do you think her chief complaint is? Anybody?
The mandibular crowding.
Yes, very good. Exactly, good. So she's actually a BBC correspondent from the US. So she's on camera all the time. So here she is, progress. Now, look what's happened here. Of course, she had some perio surgery previously, but we unravel those lower incisors, and all of a sudden she's got these nice black triangles. But on camera you don't see it, which is good. But here you can appreciate the space that she's got. I decided not to move the wisdom tooth. Initially, I wanted to line everything else up first and then sequentially move that tooth later. I thought that was going to be too much to do initially. And here she is at the end. And we actually moved that wisdom tooth to substitute for the second molar. And she's very happy. So you can see she should have had a palate expander when she was younger. You can see how narrow her palate is, but here she's much wider. So you can get some expansion, AJ, but not as much as if she had had a palate expander when she was younger, which she probably could have used. And here's the lower. But you can see the black triangles here. She didn't want me to do interproximal reduction. That was her little thing. And again, these are the other kinds of aligners. These are the Spark. And these are the indications, as you asked before, crowding, open bite, cross bite, class 2, deep bite, AP correction, spacing. So nice thing with a class 3 case, like I started a case today, a teenager who had had a complete anterior crossbite as a child. We fixed that. And I said to the mother, look, once he starts his his growth spurt when he's like 16 years old, we're going to have to start treating him again. And lo and behold, he came in today and he's edge to edge, lots of spacing. So he wanted clear aligners, and it's going to work great because he's going to wear the aligners and he's going to move the posterior teeth on the top forward, the mandibular teeth back. He's going to wear some rubber bands, and he's going to have a nice correction.
Dr. Schupak, it listed a deep bite on there, and I thought you said
Right. So
that
with the deep bite, we have these little bite openers that we put. I don't have a little thing to show you.
oh right, you mentioned on the paddle side.
Yeah. They're called bite turbos, but they're not bonded on, but they're little additions of plastic, which help the level the lower arch. That's this right here. That's a bite ramp. So it prevents the patient, they can't bite all the way together. And so that allows the posterior teeth on the mandibular posterior teeth to erupt. Usually when you have a deep bite, and maybe we'll get to another case that has that, there's super eruption of from lower canine to canine. So you've got like a two-step occlusion. The molars and the premolars are at one level, and then the canines and incisors are at another level. And so what you like to do to open up the bite is you like to level that plane of occlusion. And so if you have these bite turbos here, it allows that plane to level faster, especially if you've got the two layers of plastic, because if they're biting, if the layers of plastic are biting together, that's going to have an intrusive effect on the posterior teeth. So here's a guy. This is a great case because this is probably one of the only cases where I didn't have to do a refinement. So, his chief complaint is just he's got some crooked teeth. I don't think he ever had braces before. And he was super excited to get some aligners. And I want you to look at this area here. He's got some recession, right? He's got like no bone around the facial surface of this lower left canine. And so that's something that we have to really be careful about, because when we're aligning teeth, if we move all of these teeth facially, this is going to move facially also, and then you're going to have more recession of the gums. So you're trying to avoid that. And a lot of people, like the previous patient, don't like IPR, interproximal reduction. They don't like when you file in between their teeth. They get all huffy about it, but sometimes you really need it. So here he is. He's got some bone loss. So we certainly don't want to give him any more bone loss. And here he is at retention, which is a nice case. Smile looks a lot nicer. He's really happy. Needs a shave. This is not even COVID. Okay, so it's a nice alignment. Nice alignment. But here's what you have to, you know, strive for this kind of a result. Look at that. So usually with orthodontics, you're not really helping the periodontium in an adult. But here, look how much better that looks. It's nice. And that's because we did some interproximal reduction and we were able to bring that canine more into the alveolus. So that's what you're striving for. Sometimes you have to actually extract a tooth. So here's a young lady, and you can see, you know, this tooth is really blocked out, and if she has very thin periodontium. So if we just lined up the teeth, or we did interproximal reduction, you know, her gingiva would be, you know, to the floor. Can't do that. So you can see how thin this is here, right? These lower incisors are so flared forward. There's like no bone here. So here she is with one lower incisor extracted, and you know, the gum level looks a lot nicer here. Okay. And here she is at the end with a bonded retainer. So sometimes extracting a lower incisor is the best option. Here's another one with a lower incisor extraction. You want to take an impression, a regular impression on this lady? No way, right? It's a good thing we've got a scanner. So you can't even tell that, you know, you've extracted a lower incisor. And here she is at the end.
Dr. Schupak,
Yes.
how do you approach the option of extracting teeth? I imagine patients aren't very excited to hear that that has to be done to them, especially if it's in the front, because I've only really heard of extracting premolars.
Right. Yeah, patients hate that. But what's nice is that, well, the previous patient, you know, we extracted the tooth, there's almost no space left. So sometimes they're so crowded that even when you extract the tooth, it's like, you know, 2 or 3 millimeters. Now, what's nice is in the aligners itself, in the aligner, you can actually put some material and fill in the pontic space so that they don't even, you know, no one would even know that they're missing a lower incisor. So yes, that is one reason. That's the biggest reason why people don't proceed with treatment. It takes them a long time to get their head around that, you know, taking out a tooth, whether it's a premolar or incisor. Now, the reason why we had to take out an incisor in this particular case, and of course we took out the central, is because she had a crossbite. So there was no way to move that canine lingually without removing a tooth. And that's many times that's the reason, because you've got a canine and crossbite and you've got to move that tooth in. And there's just not enough space.
I just have a quick question. Do you
Yeah. I can't hear you very well. I don't know if it's your microphone.
like just like how does the tooth movement affect?
Do you hear her? I don't hear her.
Kristen, we aren't able to hear you. If you maybe just want to write your question in the chat.
Yeah, your microphone isn't good. So this is a great case for like a, you know, I mean, most of those cases that I was showing you are cases that I think an orthodontist can treat, but I think this is a case that even a general dentist could treat. So what we were talking about before, class 1 open bite spacing, you know, this is the easy peasy case, really easy. All you have to do is bring back the upper and lower teeth, close the space, and you're done, and you're a hero. And then I get to treat her twins who had an open bites. You could put your fist in their open bites. Her kids had such big open bites. Crazy.
Dr. Schupak, I think this is in regard to the last case, but Kristen was asking, do you bond the crown? That's all she wrote.
So, you know, let's get back to AJ's question before about cases that are best treated with aligners or with fixed appliances. So if you have a patient that has a lot of crowns, you know, braces don't stick as well. So I generally don't put attachments on the crowns. So is that the question, Kristen?
Yeah, you answered it. Thank you.
Oh, now I can hear you. La Bruna, relation to any La Brunas that have been to Columbia before?
Yeah, my dad,
Who's your dad?
Vincent.
Vinny?
Yeah,
No way. I love you. I love your dad.
thank you.
Tell him I said hi. I'm one of his favorite people.
Okay, thank you.
All right. So getting back to this nice lady. So she's got a lot of dental work, right? Tons. She's actually from Turkey. So most of this dental work was done in Turkey. And so look, she's got bridges and all kinds of jazz. So you can selectively not move a lot of teeth when you're doing clear aligner therapy. You can like freeze some teeth and say, okay, I'm not going to move those teeth. That's a lot more difficult when you're dealing with fixed appliances. So here she is, class 1 open bite. She's bimaxillary protrusive. And here she is after treatment. Now, one thing that you can notice is that she can actually close her lips together a lot more comfortably. Before and after, such an easy case. And you're a hero because, wow, looks a lot better. What happens if she doesn't wear her retainer? Bing, goes right back. Because it's the tongue, right? Tongue is opening that space. Thank goodness. I know she wears her retainers because I still see her with her kids. Okay. So here's a case of an anterior crossbite, and he's got the implant in already, which is good because during the course of the treatment, he can, you know, this can osseointegrate and we can move his teeth while that's happening, which is nice. Of course, his chief complaint is it looks like I'm missing a tooth, right? Yeah, he didn't like that so much. So here he is before and after the implant. And what do you think the toughest thing is about this case? And one of the things that Invisalign doesn't do very well. Come on, Kristen LaBruna, you should know this. Yeah. Your dad's an orthodontist. Okay, so I'll give you the answer.
Jumping the bite.
sorry.
That's always his answer.
Say, what?
It's like jumping the bite. That's always his answer.
Okay. Allison, were you going to say something?
I was thinking, is it difficult to align teeth while also trying to move them around an implant?
Well, I'm keeping that implant space there. The problem is this incisor. So the the most difficult thing to do with aligners is to torque the roots of these teeth. So the root of this tooth was very palatal, right? And to get the root of that tooth to come forward is very difficult with Invisalign. It's not so easy with regular braces, but with Invisalign, it's even more difficult. So I never really was happy with the way the root of that tooth looked. And I kept trying and trying and trying. And finally he was like, they're fine. I'm good. Let me finish. All right. And there he is with his crown. And I still am not so happy that, you can tell that the root of the tooth is still palatal there. No, I don't like that. But, certainly is a big improvement. And also, we can also look at the root of this canine. It's hard to move the root of that tooth lingually. Very difficult. It's much easier with braces. So here's another open bite case. Now she had previous ortho, and she's got her bonded retainer, and she had 4 bicuspids extracted. So a lot of times if someone has an anterior open bite, in order to close the open bite, you take out teeth and you bring them back, and that's how to close down the open bite. Not always the best option, but that's what this woman had. And of course you can see the shape of her maxillary arch is like a triangle, right? And the shape of the mandibular arch is more U-shaped. So it doesn't quite fit. And you can see that tongue is trying to get through there. And that's the etiology of the problem. And of course, she doesn't like the fact that her lateral incisors are overlapping. So you're limited in a case like this to how you're going to treat the case and how your result is going to be maintained. So now, oops. So you see this is the progress. So we're changing the whole shape of the maxillary arch, which is nice. And this is her at the end. Much nicer. But of course you're limited because you're not moving the mandibular teeth around. So you can see that the whole shape of the maxillary arch has changed, which is nice. Corrected the crossbite there. And she's much happier with her smile. So what's a class 3 malocclusion? You got a small maxilla and a large mandible. That's usually the case. Or a small maxilla and a normal mandible, or a normal maxilla and a large mandible. This is probably a surgical case. So do we have a dental problem or a skeletal problem? Are we going to compensate using a dental correction, or are we going to decompensate the patient and then opt for orthognathic surgery? So one way to compensate is to take out 1 mandibular incisor, or 2 first premolars, or do some interproximal reduction. Or if they have spacing to start with, try to close that lower space like the patient I saw today. Bring those mandibular teeth back and together, or bring the upper teeth forward. Sometimes you want to open up spaces so that you can restore, make the upper teeth larger. Sometimes they have small upper teeth and you can open up some spaces and correct the anterior crossbite that way. So you have to figure out how much space do you need. If you're extracting a lower incisor, you want to extract the lower incisor that looks the worst, that has the worst periodontium, or which one is like way out of the arch and just like, You know, it's in such a poor position that that's the likely tooth to extract. Which one has the most wear? Sometimes you've got a lower incisor that's, you know, that's half the size of the way it was originally. And that, of course, that tooth would be very difficult to restore. So that's the tooth that you choose. Also, you have to choose where your canines are. So of course, the ideal thing is to get the canines in the perfect position and then figure out where the other teeth are going to go. And so if you can figure out, sorry, hung up on them. If you can figure out which canine is the in most severe class 3 position, then you can move that canine towards the correct position, and then you know which tooth to extract. And so that's the way to figure it out. So as far as premolars, well, those are so, you know, much bigger teeth. So if you've got a lot of crowding on the lower, then you can extract premolars. But you don't want to extract premolars unless you have a lot of crowding, or else you're going to move the teeth too far lingually. You're going to tip them too much, and then you're first going to give yourself some perio problems. So hopefully you plan all this stuff out before you actually start moving the teeth around. So here's a guy, he's class 3, and what is his chief complaint? Anybody? And he's got a common chief complaint, this guy.
Is it about his smile being edge to edge? Or like he's not fully biting down, I guess, with his smile?
Well, you're close. His chief complaint, and this happens a lot with people, they tell me, I'm chipping my upper incisors. My incisors are getting worn down. I keep chipping my teeth. It's very uncomfortable. You get that. And so this guy, you know, he's a good looking fellow. And you can see that his mandibular and maxillary teeth are both tipped lingually, right? So you're not so excited about moving his bottom teeth forward, right? You'd like to move his top teeth forward, tip those guys out a bit. This is not a very good representation of his ceph, but his teeth are really straight up and down. And here's some models of his teeth. Look how straight up and down these teeth are. They're so flat. Also has this weird crown here. He's from Germany. He had some weird dental work, a weird haircut. But so this was very simple. All we did was we just tipped the teeth forward and got him some overbite and overjet, and he was happy. That was it. That was easy. Super easy. And of course, cosmetically, he looked nicer too. But you're going to get that. You're going to have people come in and say, you know, I'm chipping away my upper incisors. What can I do? And, you know, some cosmetic dentists will say, oh, we'll just, you know, put on some veneers. But unless you move the teeth first, you're going to have a lot of problems with wear of those lower incisors. The housekeeper's here. Let me just close the door. I'm in a meeting, so I'm going to close the door, okay? All right. There we are. Okay. Another nice class. Am I going too long? No? What time should I stop? Allison?
We can keep going if you want. Maybe until around like 8:15ish, 8:20.
Okay. Okay. Yeah, good. Whatever you want. I'm
Yeah.
fine. Okay. You know, let's go to somebody. Let's get to a different case. Oh, this is a good case because this has something to do with cosmetics. So what we were asking before, so this is more easily treated with braces than Invisalign, but she didn't want braces, just the tipping of those teeth. And I just want you to see, look at the difference in the height of the central incisor. So this central incisor has had a lot more wear because it's more palatal. So this tooth never really had an opportunity to wear, and you can see the difference in the gingival margins here, right? And she's a young person. I think that she had previous ortho, but my memory serves me correctly. And so as we were correcting the position, I was constantly adjusting the length of this incisor as we were evening out the gingival margins. And this is her at the end. So you would never know that these teeth were different sizes originally. You can see I'm a big fan of these bonded retainers, right? This is not a good case. So let's talk about class 2s and then we'll call it a day, right? Again, small mandible, large maxilla, normal mandible, large maxilla, small mandible, normal maxilla. Is it a dental or skeletal problem? So let's talk about this young lady. So she's going to have regular braces, and you can see that she's got a deficient mandible, very deep bite. And see how her lower incisors are biting almost right into her palate. And here she is. She's, you know, very good rubber band wearer. And here she is at the end. A nice result. Don't worry about a gummy smile in a little kid, because as you get older, that decreases. Plus the fact she's got, you know, she's got swollen gums there. But it's interesting. When I was a kid, I was very gummy, and now as an adult, I'm not at all. So. And here's a nice guy, nice class 2, right? Class 2, division 2. You know the difference between division 1 and division 2, right? So this guy is an actor, and his wife kept bugging him to get his teeth straighter. I treated his kids, and finally said, all right, I'm going to do it. So here he is. He's got a nice big overjet. And if you notice, he's my age, by the way, this guy. And look at, he's got a nice profile change. And then he goes and gets these laminates on, or crown, yeah, laminates on his teeth. He thought that looked great. Not my favorite. But look at this in an adult. You wouldn't expect to see a profile change, but you can. It's nice. So this is before the laminates. And now he's got the laminates. Look at all these people that should have had palate expanders, right? Super upright, you know. I don't know if you guys did Ceph tracings, but 90 degrees is fairly it's actually a little bit, it's normal, but this guy's probably at about 80. These teeth are really, really upright. And so we tried to open the bite, not so easy in a guy. And we also tried to do some expansion. Not so easy. So our palatal expansion in kids is just fabulous. I treated his kids too, and we did palatal expansions. Of course, as soon as I saw them, it's a palatal expander. He's like, yes, of course. So maybe this is our last case. Okay, let's see if this is a good one. Wait. Let me show you. Oh yeah. So let's just do this one and then we'll call it a day. So this is a teen. She's, I don't know, 9th grade maybe in this picture. She's still exfoliating premolars, and she was one of my first Invisalign teen cases. I treated her brothers, and her mother said, she's a nincompoop. She's never going to wear it. She's a knucklehead. And Emma, that's her name, she was going to prove her mother wrong. She's like, forget it. I'm going to be the best Invisalign patient that's ever been. So here she is. She's still in her late mixed dentition. Very upright incisors, class 2, dip 2. And here she is. She's edge to edge. Is that crazy? She was going to prove her mother wrong. And here she is at retention. Socked in class 1 occlusion. Socked in. She was amazing. And nice profile change too. Look at that. This is Invisalign. So people who say, oh, you can't correct the bite with Invisalign. No, you can. It's actually easier in teenagers.
Why is it easier?
Why is it easier? Because the plastic keeps the bite open.
Oh, right.
Yeah. Okay. I think we're good, right? What do you say?
Perfect.
Thank you so much, Dr. Schupak, for your time. It was an incredible honor. We can't thank you enough. We can open it up for a few minutes of questions, last minute questions.
Sure. Absolutely. Let's do it. Are these questions in the chat or?
So I think we had some questions earlier in the beginning. I don't know if this one was addressed. I know Rumi's question and Kristen were answered, but Michelle had a question about what is the advantage to having specific brackets? Does it help with alignment?
Sorry, that was for the 3D brackets, but I think you answered.
Oh yeah,
that
for
with
sure.
Airways. Thank you.
Goes much faster. Yeah. And do you bond to the crown? You can, but it's it's not so easy. I mean, the brackets don't stick to those crowns as well. It depends. So there's some porcelain where it's very difficult to bond, and then other porcelains that it's less of a problem. Yeah.
Does anyone else have any questions for Dr. Schupak about orthodontics in general or what she does in private practice? As a Columbia alum, now is your time.
Applying to residency programs. I do interview kids for NYU, so I know a little bit about interviewing and what you need. Research. Present.
So I have a quick general question, and this might be like dipping into the business side of orthodontics.
That's okay. Good.
But I know that you said before Invisalign, there's some things that you cannot do, obviously. Plastics can, in which cases that brackets are needed. But given the advent and the growing popularity of Invisalign among like general practitioners, general dentists, have you found that a lot of them still pursue using Invisalign in those cases where even though it's not recommended, they won't find an effect. And then I guess those patients coming back to you after a few months with those general dentists, like, oh, he wasn't able to fix it, that kind of thing? Or no, general dentists know their boundary and then they say, I can't do it. We have to refer.
You don't know what you don't know, unfortunately. So, there are some, just like in your class, I'm sure you know some of your classmates, they know what they know or they don't know what they don't know. So look, there are plenty of dentists out there who are doing Invisalign and doing a fabulous job. They know when to treat, they know when not to treat, they know when to, what teeth to move. I've had patients who've come in, like I have a patient I saw the other day. I'm treating the 3 boys with Invisalign, and the mother was treated by a prosthodontist in my building and with Invisalign. And she had an aligner in at her first visit to see, when she brought her kids to see me. And I said, oh, you're having Invisalign treatment. She says, no, this is my retainer. Her teeth are like, all bunched up. I said, oh, no, you can't move them any further. I'm thinking, yeah, right. Yeah, because he's a prosthodontist. You can't move them any further. So, an orthodontist can make it perfect. But, so I'm not doing fillings because I'm not a prosthodontist. I'm not I know what I don't know how to do. I'm not going to do that. I'm not doing endo.
Got it. Thank you.
But there, like that case, that Turkish woman, any dentist could do that. That's an easy case. You don't have to be any genius to do that.
Speaking of prosthodontists, how do you work around patients who have implants?
Well, obviously an implant can't move. So like I started a case today. And so if you're doing aligner therapy, you sort of freeze certain teeth. So you can't move the teeth around where the implant is. Sometimes if you're planning for implants, of course, that's another story. So if you're opening up spaces for congenitally missing lateral incisors, that is not a good Invisalign case because the roots of the teeth do not tip very easily. So just when you're thinking about Invisalign and you're thinking about tipping roots, mesial and distally, or that case that I showed you with that fellow that had the lateral incisor that was very palatal, it's very difficult to move the apex of that root with a removable appliance. Very hard. Yeah.
Thank you.
So I think we just have a few residency related questions.
Go ahead.
Ali is asking any advice for writing personal statements for orthodontic residencies?
Well, I mean, the best thing is to be honest and, to really, I want to help people. I mean, I don't know. I mean, as far as, personal statements, just be as honest as possible, and try to be as unique as possible as well. But my biggest, the best piece of advice that I can give to you is to do research, publish, and present. That really gives you points. If you don't get into ortho the first year, do a GPR. My last 2 associates did GPRs before they did ortho. I think they learned a lot and it really, it made them better orthodontists. So if you don't get in day 1, there's still time. Don't be discouraged.
And Zaid is asking, what are some things outside of research that you would like to see in an ortho applicant?
Well, if there's an ortho elective that you could do, that would be great. Try to do, and do you have that at Columbia? Yeah, you could do, just do as much as you can in the orthodontic department.
You can go up more often to VC9 if you want to assist and shadow and
yeah,
you have the time. Yeah.
I mean, at NYU they have an ortho elective. I mean, an honors program. And I know at Penn, where my daughter went to dental school, they had something like that also. I was just, when I was in dental school, I just tried to do as many ortho cases as I could. So make
And our
myself
last-
known.
Oh,
And I did research and I did presentations and I got right in.
awesome. And our final question of the night is asking if research is a required component to apply for ortho.
I don't know if it's required, but it certainly is very helpful. I can tell you at NYU, because that's where I interview, it gives you a lot of points. So it's a point system. You know, you've got, you know, 3.7 cum. That gives you a certain amount of points. You've got research, that gives you points. You did a, you know, you got a master's degree before you went to dental school, that gives you points. You did, you know, this, that, or the other. It's all points. And then once you have enough points, then you can proceed to the interview process. So that's my hint for you guys, because nobody knows that. And that's NYU. So I can tell you that the valedictorian of my daughter's class at Penn did not even get an interview at NYU because there was no research, none, and no outside activities. Number one in the class, but nothing else. And this individual got into another orthodontic program and is, I'm sure, perfectly happy, but not going to get in at NYU without that. So, not that NYU is the best program. I think it's a very good program. And I think one of your other questions should be, you know, programs where you pay or programs where you get paid. So just to let you know, I probably would have been, I mean, there was only one paid program in my day, and they have, and it's at Einstein in Philly, and they only do it every other year. It just so happens that my classmate, Vanessa Morenzi, is the chair of that program. But it was an off year when I was applying, so I couldn't apply there. It wasn't an option. But most of those paid programs, I'm sorry to say, stink. That's not to say that, you know, you can't become a good orthodontist, but they're not anywhere near the other programs where you have to pay. Look, I probably, if I had gotten into one of those programs, I probably would have gone and I probably would have been fine. So, but the programs where you pay, you know, generally are much better programs. Generally, I'm not going to say all of them. That's something to consider.
Thank you so much, Dr. Schupak.
yeah,
And thank you for taking.
instrumental. We can't thank you enough for donating your time.
Sure. Anybody else have a question? Last chance. So hopefully next year I will get to actually see you guys in person, because I do help facilitate the ethics program. So hopefully we'll be able to do that next year, and I'll be able to meet you in person. So if you know, if you want to email me personally, Allison, you can give out my information. I'm happy to answer any questions.
Perfect.
And, yeah.
Thank you.
You're very welcome. Nice to virtually meet all you guys.
Thank you so much, Dr. Schupak.
You're very welcome.
Great night.
Take care. Good night.